people here in the room and then those who are joined remotely. I'm Dr. Senthil, one of the diabetes endocrine consultant. I want to do the diabetic emergencies, but I don't think I can do everything today. I wanted to do three things: one of the DKA, HHS, and then the hypoglycemia. So we'll see when time allows. Yeah, okay. Before that, I stopped on the DKA. So if you can tell me, or the people who have joined remotely, what would you want the outcome to be from this the teaching? Would you want any specific thing that I can see whether I can incorporate while I'm doing the presentation?
Okay. Diagnosis, basic management, any new changes to the management?
Yeah. Okay. I hope I will cover it.
One thing specific cropped up as well, like euglycemic decay that we need to.
Yeah, that's there. Yeah. Okay. Okay. So I'm going to talk some quickly the normal physiology and then what is diabetic ketoacidosis, and then these two the hyperosmolar and then the hypoglycemia. If I have time, then we will come up with some the learning points for you. Yeah. Okay. I think I'm not sure whether you want the US or the UK one. The pathogenesis, glucose homeostasis. I think more or less that's the same. I think the important thing is the liver and the pancreas, yeah, predominantly. Okay, so when we eat, the blood sugar goes high, and then that stimulates the beta cells in the pancreas to release the insulin. Okay, that insulin helps the body or whatever the tissues that they need the glucose as an uptake. With that, the blood sugar drops when the blood sugar the reaches the 4 millimole, then the insulin production from the beta cell switches off. And then if the blood sugar goes lower, the alpha cells in the pancreas switches on, and then that causes that's the glycogenolysis. It's break down the glycogen, which is the main source is the liver. The glycogenolysis end product is the glucose, and then try and then maintain. Yeah. Okay. So that's how the homeostasis. So if I just use I think the same. We want to maintain between 4 and then the 6 millimole. Yeah. Okay. Between the alpha cells and then the beta cells in the pancreas and the liver. Yeah. Okay. That's the predominantly. Yeah. Okay. So as I told you before, for the why that if the insulin is needed. Okay. When insulin is not available, the glucose is not able to enter into the cell. Okay, so the important thing is that GLUT receptor, glucose transporters, or GLUT4. Okay, so when the insulin binds to its own receptor, and then the glucose transporters will attach to the cells, and then that will allow the glucose in the bloodstream into the cell. Okay. That's how the insulin why it's important in the diabetic in diabetes patients. If the insulin is not there, then the end result is there's too much blood sugar in the bloodstream, not going into the right areas. Yeah. Okay. When I say it's just some more background about the diabetic ketoacidosis. Yeah. Okay. In the UK, the National Diabetes Audit, 3.6% of the type 1 diabetes has, the episode of the DKA, and then 4% then they developed it on type 1. Okay, and then also the DKA may be the first presentation of the diabetes. So in 6% of the diabetic patients, so they present with the DKA and then they're diagnosed as the diabetic ketoacidosis. I think in early, the late 90s and then early 2000, the mortality was somewhere around even up to the 20% being quoted. Okay, but lately the mortality has improved dramatically. Okay, I think that's mainly based on how we understand the diabetic ketoacidosis, and then the more access for monitoring the blood sugar, blood ketones, and then now we have a national guideline. Okay, the ABC, the Association of British Clinical Diabetologists, they've come up with the management of the DKA, which now been widely used in the UK, but that's also been used worldwide. Okay, so better awareness. Okay, one thing, better availability of the resources, and then a targeted, the algorithm treatment management. Okay, it all that helps with reducing the mortality to the less than 2% now. Okay. One other thing is that still 8% of people who are admitted the type 1 diabetes without the DKA, they develop the DKA in the hospital. That means that should be a never event. Yeah, okay, predominantly happens if the patient are ill by mouth or they become unwell. Okay, so you need to, yeah. Even though we say DKA is more common in type 1, now we are seeing in the type 2 diabetes also, especially Dr. Khan mentioned about the condition euglycemic diabetic ketoacidosis. I will talk about it here. Okay. And then there are other ketosis prone diabetes. Yeah. Okay. But you don't need. Like somebody asked for the diagnosis, the DKA. All three needs to be there. Yeah. Either they're non-diabetic or the blood sugar more than 11. Okay. That is D. And then the ketosis, we want capillary ketone. Okay. So if the capillary ketone is 3 or more, but if there is no provision to check the capillary ketone, then the urinary ketone at least 2+ or more. But you have to ask for the capillary ketone, yeah? So 3, okay? And then the acidosis. So acidosis, bicarbonate less than 15, plus or minus pH less than 7.3. So all three need to be there, yeah? Diagnosis clear, yeah? Okay. Non-diabetes or BM more than 11. Ketone 3 in the blood ketone, or urinary ketone more than 2+, and then acidosis bicarbonate less than 15, and the pH. Yeah. So when I just coming with the pathogenesis, I told you the insulin is important for the glucose to entry into the respected area, the muscles, liver, brain, everywhere. Yeah. Okay. So what happens when the glucose is not there? Okay. So in the bloodstream, very high blood sugars. Okay. What happens that it becomes hyperosmolar, isn't it? So when it is filtered by the kidney, okay, the glucose is an osmotic agent. So it drags water along with. Okay. So then, the people will have glycosuria along with the polyuria. So when they have that the polyuria, okay, that's when the electrolyte losses happens, the renal failure, and then the shock. Okay. So that's in the renal, yeah, in the kidney, what's happening is predominantly the glycosuria, polyuria, along with electrolyte losses, leading to hypotension shock. Okay, and then if you take the other side, when there's insulin deficiency, okay. So when the insulin is not available, the glucose is not able to enter into the bloodstream. The cells need to survive. Okay. Without the energy, it's not going to survive. So when it is trying to produce the energy, it goes to the least efficient way of producing the energy. That is breaking down the lipids. Okay. So when the breakdown happens, the final end result or the end product is the ketones. Okay. So that results in the ketosis and then the acidosis. Yeah. Okay. And then that leads to cardiovascular collapse. So if you add two together, yeah, the one side the significant fluid loss with the electrolyte losses, and then the other end the lipolysis, and the end product is the ketosis and then the acidosis. Yeah, and then the diabetic ketoacidosis. Yeah, you happy? I think very simple, the way of explaining. Okay, it's the another diagram, the puts. I think I've given it to Arif. Arif, if you want, you can share it with them. Yeah, okay. So here, what it says that the unchecked gluconeogenesis leading to the hyperglycemia, and then the osmotic diuresis leading to the dehydration, ketogenesis leading to ketosis, and then the anion gap. Yeah. Obviously, you need to look for what is the reason that patient presenting with the DKA, the precipitating event. Yeah. Okay. So if you guys can tell me what's the commonest cause for the DKA?
Action.
Okay, the most commonest that we come across is poor compliance. Yeah, okay, and then like the infection that can be like one of the trigger. Yeah, okay, and then as I told you before, the 6% like they present as the DKA, so the new diagnosis type 1 diabetes. Yeah, okay, so that you should be aware of it. But most common is poor compliance, then followed by the infection, predominantly like the viral infection. I think because of the time that I will leave that the physical exam finding. Yeah, okay, I think so. You also, when you are diagnosing the diabetic ketoacidosis, you need to find out whether is this the severe diabetic ketoacidosis. Yeah, okay, because in severe diabetic ketoacidosis, the recommendation is that you need to involve more senior team, like the level 2, level 3 care. Okay, yeah, it's not like the simple the DKA. Okay, so we have had like quite a few incidents. It's still like the ongoing. We're still debating with the the intensive team. I think you guys I think take the most of the brunt, and they come with very severe. Not only for DKA, I think majority of the other clinical condition. We've been asked to like whether you could manage improve the patient condition in ED research. Okay, but if you have look out for the severity. Okay. So it says ketones more than 6. Okay. Some of the criteria when you look at it, it may look soft. Because of that only like the mortality had come down. Okay, so you have to still if you come across. Then especially like the pH less than 7.1, or if they have evidence of SIRS or like the sepsis. Yeah, okay, like hypotension, tachycardia, okay, reduced GCS, yeah, okay. And like there are, and then whether one another important is like hypophilia. Okay, so I think one of that the take home message would be okay when you're managing under the DKA, what you should be doing if somebody presenting with the hypophilia. Yeah, okay, make sure. And then some of the patient factors will influence. Okay, that would make it as a severe DKA. Can you give some examples which patient group that you would feel like they will be going into severe category? Young and the elderly. Okay, so elderly, renal impairment in younger. Why is a young? What problems that you could expect? Okay, so you're okay. I'm going to catch you here because you're a medical student. You should be knowing more like in the physiology. Okay. Why? Anybody?
I don't feedback loops more rudimental.
No, I think what happens in predominantly, they have, when we are replacing the fluid, the amount of fluid, yeah, okay, that very high risk of developing cerebral edema. Okay, so that's why, yeah, okay, that's the young and then elderly. Obviously, the other end, like they will have multiple comorbidities when you're giving too much fluid. What other one or two, if you just tell other category, patient category that they will.
I've come across patients that have had like learning needs and things like that with, and as a result of their disabilities.
Make it like
Yeah,
it
yeah.
difficult. Yeah. Okay.
Obese patients?
Obese patients. No. Pregnant women. Okay. And if somebody like has renal, liver, or heart failure, then like your fluid management going to be like very difficult, isn't it? So yeah. These are all the patient group like will influence whether that is severe, and then the biochemical parameters and then the clinical parameters to look at it. Yeah, yeah, okay. I usually tell like in somebody that who has the DKA, okay, that the water deficit like 100 ml per kg. We usually take it I think we have to move it away. Usually say it's 70 kg. I think we are all big heavier. Maybe we need to make it as 80 kg something. Yeah. So 70 kg man, like if it's 100 ml per kg weight loss or the fluid loss, not the weight loss, the fluid loss from the dehydration I told you from the renal. So the deficit will be like somewhere like the 7 liters, isn't it? So that you need to be like aware of it. One other important is the potassium, like they are the deplete. Okay, along with the sodium, the potassium will be also like the deplete. Yeah. Okay. This is a new guideline that had come up in 2021. Okay. So you can access, yeah, okay, it's there, yeah, okay. So the ABCD guidelines 2021. It's a very busy slide, okay, but I think I want to make it simple, okay. So I would want to say like 5 steps, okay, in the managing the DKA that would incorporate everything, yeah, okay. So it is available in Diabetes UK or the ABCD website, and then the link is there, so you can just go on there, yeah, okay. Okay, so in the diabetic ketoacidosis, okay, from like the what I like I have told you, okay, what is the problem? Then if you understand the problem, then we like go and then treat it accordingly. Yeah. So what are the problems that you are telling?
Yes, glucose,
Hyperglycemia, okay,
hypokalemia,
keto, ketosis. So because of the insulin deficiency, okay, the like what has happened, like the significant the fluid loss that the patient is having. Without the fluid loss, that multiple electrolyte imbalances that the patient is having. Yeah, that's the one arm. The other arm is like the unchecked the gluconeogenesis, okay, resulting in significant ketosis and then the acidosis. Okay, so that if we address that the two, okay, then it is the management of the decay. That's simple. Okay. Yeah. So the step 1, okay, is establishing the diagnosis. So I told you like the DKA, yeah, with the DK and then the so you're establishing the diagnosis. Okay. The step 2, okay, to do like necessary investigations needed or finding out the facts like why this patient presented with DKA, along with what necessary investigations to be done. Okay, so that like we are establishing like the severity. Okay, that will be like the step 2. The step 3, okay, it's the fluid management. Okay, the single important one that that you should be doing. Okay, fluid replacement. That the fluid replacement will address the dehydration, electrolyte balance, everything. Yeah. Okay. Then followed by the insulin administration. Okay, so the aim like why we are doing the fluid replacement is one obviously like restoring the volume, yeah, and then when you are restoring the volume like you're flushing the kidneys, isn't it? When you're flushing the kidneys, what happens like the ketones will be like cleared, and then you are correcting simultaneously like you are correcting the electrolyte imbalance, yeah, okay. So I'll come to that one later, yeah. Okay, so the fluid, yeah, okay, the choice. When they present, and then if no evidence of circulatory collapse, yeah, that means they are not hypotensive, they are not tachycardic, okay. The first liter should be given as a over 1 hour, and then in the first bag, no potassium. Very important. These are all like the practical points. The first bag, okay, if they do not have a circulatory compromise, you are giving it as over 1 hour, yeah, and then no potassium in it. If there is evidence of the circulatory compromise, yeah, hypotensive, tachycardic, yeah, then you are giving that to the 1 liter, okay. You can give that to the 500 as a start, and then another 500 depending upon what's the response also as a start. Okay, so if circulatory compromise, give the first 500 start because everybody like maybe bit worried to give like 1 liter as a start. Okay, but if you are brave enough and then the patient is has reasonably good cardiac and then kidney functions, as I told you already, they are 7 liters water deficit and they start with the DKA. So you should be able to give that the 1 liter as a start. But just like give 500 ml as a start and then followed by another 500 ml start. Okay. If no circulatory compromise, over 1 hour, and then no potassium in it. Yeah. And then the second bag and then the third bag over 2 hours and 2 hours. Yeah. And then fourth and then the fifth bag, 4 hours, 4 hours. Yeah. The sixth bag over 6 hours. Okay. So if you know that, if I ask you, no, I'm sorry, maybe later. Okay. So at the end of 3 hours, if the patient has received an appropriate treatment, how much fluid should have finished for that particular patient?
5.
At the end of
3 hours.
at the
5
end of
liters.
3
3 hours, yeah, 5 liters.
No,
two and a-
2.5.
Liters. Oh,
Depends if there's circulatory.
Yeah.
yeah, 2 liters.
The circulatory is good.
So
2
you would have
liters.
given one in 1 hour, and then you would have given the second in 2 hours. That would be in 3 hours.
So in 3 hours, it's
2
3
liters.
liters. So 2 liters. Yeah. Okay. That's what you should be learning. Okay. So if I say at the end of 5 hours, yeah, should have received 3 liters. Yeah. 9 hours, 4 liters. Yeah.
Yeah.
Yeah. From the third bag will be over 4 hours, isn't it? Yeah. Okay. So that I think that this is the important thing. Okay. This is where sometimes we have come across they are not managed adequately. Yeah. Okay. So that you need to. Yeah. Okay. Easy to understand. Yeah. So 1 hour start and then 2 hours, 2 hours, 4 hours, 4 hours, and then the 6 hours. Based on that, yeah, you can tell that how much fluid that the patient will require.
Is there a local audit done in how many percentages of DKA we are not managed adequately?
Currently, we have set up Midland-wide the DKA registry. There's 1,500 audit episodes. Yeah. Okay. In that, still if I say around 20-30%, that is not adequate, appropriate. Yeah. Okay.
Significant amount, isn't it? 30% is quite a lot.
I will come up with a few examples there, why that has happened, why, yeah, what it could be. Okay. Then the next, the practical point, it may not be important, because you are in ED, but if you are, okay, this one, you are going to introduce a 10% dextrose when the BM drops below 14 for the first time. Okay, that should be one of the learning points. Yeah. Okay, so you are adding, not replacing. You are adding 10% dextrose to the existing fluid that they are receiving. Okay, and then the rate is it's fixed. Okay, 8 hourly, 125 per hour. This one I think I've already
Do they have 2 bags of fluid running?
Yes.
So 2 cannulas with 2 bags of fluid.
Yeah. Okay. And then I've already told. I think I wanted to ask you guys why I'm adding the 10% dextrose, but if you have not looked at it, then I'll ask you why.
Because you need the insulin to continue to get the glucose uptake along with.
So in the DKA, the initial management, okay, I'm not trying to correct the blood sugar.
Yeah.
So we are trying to reverse the lipolysis pathway. Yeah. So the only one which can reverse and stop the lipolysis is the insulin. Okay. But when the blood sugar drops below 14, and then if you are continuing, that the insulin, high rate of the insulin, they are at risk of developing hypoglycemia. So that is the reason that we are adding the 10% dextrose. Yeah, you understand? Yeah, okay. Why I'm adding 10%? It is to facilitate the stopping the lipolysis by continuing the high dose insulin infusion. Yeah, okay. There is a catch to that, but I'll come. I think I don't want to do that because it will make difficult. Okay, I'll come to that. Yeah, okay. We are going to incorporate it in the new DKA guideline. Yeah, okay. Yeah, so you understand. Okay, and then this is where the practically. Okay, so the blood sugar drop 13.5. Yeah, so you have started 10% dextrose to the patient. The next hour, the nurse comes and then tells the blood sugar is 15. What will you do? Okay, I'll say 18. What will you do? So after the fluid.
As long as the ketones are falling, we're not supposed to change it.
So this one, the 10% dextrose I'm asking, Dave, I think you can keep it. The blood sugar had gone above 19. Yeah. So 14, I set the cutoff. The next hour, they come on and say the blood sugar is even 20. What will you do? To the 10% dextrose. Now I'm
Would you
asking,
continue it?
you want to continue it? The blood sugar is
Because
raising.
the aim is to avoid hypoglycemia.
Okay, are you going to continue the 10% dextrose or are you going to stop the 10% dextrose? That's my question. Yeah.
The correct answer is to continue it, but I would just thinking about I'd probably stop it. It's getting up slightly.
Okay, the correct answer is the first part is correct. You have to continue. Yeah. Once you have started the 10% dextrose, okay, you're going to stop it when the DKA is resolved. Okay, why?
Because you're gonna increase.
No, the why, like, the practical reasons predominantly. Yeah. So if, like, it says, like, the 19, and then you say, like, you stop the dextrose. How good are communication in that the emergency setting to the nurses, and then the nurses to implement? It's pretty poor. Okay, so you say that, okay, stop the 10% dextrose, only continue normal line. By the time, like, it will be half an hour, 45 minutes, and then they'll come back and then say something else has happened. Yeah. Okay. So there were, like, the incidences, like, switching off, switching on. Okay. So to avoid all that, the confusion. Yeah. First time drops below 14, starting the 10% dextrose, and then you are stopping that only when the DKA has resolved.
So just
Clear?
practicality.
Practicality. Okay. Yeah. To avoid a lot of confusion, errors, everything. Yeah. Okay. That's another, like, the learning points for you. Yeah. Okay. So that will be, step 3. Okay. As I told, step 1 to establish diagnose. Step 2 to get all the corroborative evidences, and then to assess the severity. Step 3, like, the fluid, yeah, replacement. Yeah. Okay. And then comes, like, the step 4 and then the step 5. Okay. It can be interchanged. Okay, depending upon what's the potassium. Okay, step 4 and then step 5. Okay, if the potassium is in the normal range, okay, then I would go, the step 4 will be the insulin. Yeah. Okay, so the insulin, okay, so I think everybody that knows, yeah, 0.1 unit per kg. Okay, and then the target that, I have highlighted it in the red. Yeah. Okay, so what I'm expecting is metabolic response that I'm expecting is the blood ketone reducing by 0.5 millimole per hour. That is the metabolic response I'm expecting. If you don't have a provision to measure the ketones, then you go to the next point, like, the improvement in the blood sugar by 3 or improvement in the bicarbonate by 3. Okay, but I want, like, ketone. Okay, in the audit, we've also come up with, when they looked at the audit, in that only 25% of them having, like, the measurement of the ketones as per, like, the R-leak. So there is a significant 70% they are not having. Yeah. Okay. So the ketone dropping by 0.5 millimole per hour. Okay, that's the response. So if that response is not happening, then what you need to do, you are going to increase the insulin infusion rate by 1 ml per hour. So if they're on 8 ml per hour, yeah, already, then ketone is not dropping by 0.5. So you're going, the next hour, you're going to increase it to 9 mil. Okay. And then the next hour, if it is still not dropping, increase 10. So up to 15 mil or 15 units per hour, because 1 mil contains 1 unit. Yeah. So 15 units per hour. Okay. You're needed. You're expected to do it. Okay. So don't worry. Yeah. Too much, but you have to worry, but I'll tell you why you have to worry. Yeah, but you have to keep, like, increasing. That's when, like, you are escalating to your senior or, like, the diabetes team, like, why this is not happening. Yeah. Okay. Yeah, it's important. Another, like, the important thing, like, when you are using the insulin infusion, I think predominantly, like, this is what, like, the not happening in the audit I have seen. They start and then they don't look at the ketone monitoring. Obviously, that's not happening. Because of that, they are not up titrating, yeah, the insulin rate. Okay. I think this is simple guide, yeah. Okay, so like how much that you're going to, yeah. Okay, so 40 to 49. You are not starting 4.5, yeah. It's all like in one, yeah. Okay, 4, 5, 6, 7 like that, yeah. To make it like easier. So if somebody like you said the obese patients, if the obese patient comes there, the rate should be depending upon their weight. If they are 100 kilos, then you need to start at 10 units per hour. Otherwise, you are not going to get that metabolic response what is expected. Okay, so they need to be started on adequate insulin. Yes. Okay, and this is where like the new confusion, but the new the recent guideline in 2021 has advised. Okay, to consider. Okay, I'm still saying, okay, even like when we are updating the guideline that and we are deliberating what word like I should be putting it to make it easier for you guys. They say when blood sugar drops below 14, we were telling that there is a risk of hypoglycemia. Okay, and then there's the entity like the euglycemic diabetic ketoacidosis when the blood sugar itself is not very high. To avoid or reduce the risk of the hypoglycemia, okay, they are saying when the blood sugar reaches 14, you could consider reducing the dose from 0.1 unit per kg to 0.05 unit per kg. Okay, but I think in the guideline that I'm putting, okay, that should be done by the specialist. Okay, so I will leave it for others outside the diabetes team. Okay, or like if somebody like really experienced, okay, continue that the 0.1 unit per kg. Because the guideline has come, okay, I had to tell you, okay, so just bear in mind, but yeah, don't start that, okay, but you still continue 0.1. If you are giving the 10% dextrose correctly, then the hypoglycemia risk should be like yeah, okay, it's just the one like the difference that compared to that with the new thing. Yeah, okay, that's from the new guideline that I'm saying. And then like so that's the like the step 4. Okay, where the like can be interchanged with the the potassium. Okay, if the potassium is the first bag that you are not giving any potassium in it. Yeah, okay. So from the second bag onwards, okay, this is what like you're looking for. If it is potassium is the we take like the venous or like the lab. Okay, either one will be happy. If it's more than 5.5, you're not adding any potassium to the second bag. Yeah. If it is between 3.5 and then the 5.5, you're adding a 40 millimole. Yeah. Okay. So that means, yeah, in the second bag that you are going to give it, which is going to be go over 2 hours. So the rate would be
500 mils per hour.
yeah. So 500 mils. That means 20 millimole per hour potassium. Yeah. So I think everybody, I think we worried like whether if you give too much potassium, like okay, I have come across in ED in research, nurse is telling me, oh, this is more than 10 mil per hour, I cannot start that the infusion in the second hour. In spite of me telling that I'm a consultant involved in the protocol, the nurse is saying, no doctor, it is too much potassium, I cannot give it. I think we've addressed it separately, that one, that's like the knowledge, yeah? Okay, so for you, okay, even the nurses tells that you are giving the 20 millimole per hour in that, yeah? Okay, so you should be giving 40 millimole for 2 hours, yeah, in that one bag, okay? So the third bag also the same, isn't it? 40 millimole in 2 hours, isn't it? Yeah, and then the fourth bag, it will be like over 4 hours, isn't it? Yeah, okay. So that's another important learning point for you guys. Yeah, because that's where like a lot of the misunderstanding, confusion. Yeah, okay. If it is less than 3.5, okay, the alarm bell should ring. Okay, so this is the only situation where I do not want to start the insulin infusion. Yeah, what happens if you start the insulin infusion? Intracellular. Then what will happen? Hypokalemic cardiac arrest. In the last 6 months, there are 3 incidents. Hypokalemic cardiac arrest, 2 patients died. Yeah, when the potassium was not managed appropriately. Okay, that's why, yeah. Okay, if it's less than 3.5, the alarm bell should ring. That you should not be. That's where like you are going to delay the insulin initiation. Okay, then you are going to ask the most senior person to review. Okay, so I was just asking. Anybody been to ITU? Worked in ITU? Okay, need to call the ITU. Okay.
When potassium is low.
Less than 3.5 in a DKA. If the ITU says no, please put insulin. Yeah. Okay. Erase it. Yeah. Okay. Okay. They need to put like another IV access, and then to decide, how fast that we can give the potassium. Yeah. Okay. So the traditional like the 20 millimole per hour that we can give. So we will be starting it. Okay. And then if that patient is able to take something orally, you are starting like oral sand, okay, but it's going to take some time for that like to be absorbed. Then like the IQ like need to take the patient to intensive more close monitoring. The cardiac monitoring. They can put like proper IV line or the central line. So through central line, how fast that they can give the potassium, and then if they can be like closely monitored. That is 60 to 80 millimole per hour. Okay, but it can be done only in ITU because they need to like the invasive monitoring everything. Yeah, because everybody like will be worried about the hyperkalemic cardiac arrest, isn't it? Yeah. So that's the another important line. Yeah. Okay. So if it is less than 3.5, okay, pause and don't start with the insulin infusion. Okay. Give what's supposed to be given. Anyway, the first bag like we are going to give it as like as a stat. Okay. But the thing like from the second bag you have to give that 20 millimole. On top of that, the other source of potassium replacement need to be established. Okay. And they need to be done quickly in the first 1 hour. Even like now, I will wait for the insulin to be started, pause for like at least 1 hour for this like to be addressed. And then the ones that the potassium issue is addressed, then you are going to start with the insulin infusion. Yeah. There's another like the important like the learning point in the DKA. Yeah. Okay. This is where I had come across so many times like the issues. That's why like I'm emphasizing that this should be like that's what like you should be looking for. Okay. When you are initiating the insulin
in the first bag, can you give 20 or 1 hour?
The first bag like as per the DKA guideline
in that situation is high.
Yeah, that's when like we are like going outside. Yeah. Okay. So that's where if like in ITU that they can give up to 80 millimole per hour. Okay. When I'm just saying okay, you should be able to give it. Yeah. But that's when like we need the more senior input into that. Okay.
No, I'm saying
usual practical point, yes, that you can give.
Because you're not giving usually first bag any potassium. Yeah. But if it's hypo, can you give
it the guideline, it has not said like the first bag is without the potassium. Okay, there's still as if I'm going by the guideline. Okay, but when you look at the practical point of view, when you look at it, okay, if in ITU that they can give, okay, but you are not. The nurses will not be like happy to give the 40 millimole over 1 hour. Yeah. Okay. So that's where like the more senior input. Because guideline is guideline. Yeah.
Okay. I'm saying 20. I'm saying 20. Can you give first like 20?
You can just still like give it. Yeah. Okay. If that like the extreme situation. But, yeah. Okay. But you are going to involve more senior person to that. Yeah. Okay. That's very important. I think the another important thing when you're starting the insulin as the intravenous, one other thing like you should be considering. If they are already known diabetic.
The long-acting ones should be given.
So if they are already on a long-acting insulin, okay, that should be continued with long-acting insulin.
Okay. Alongside the actrapid.
Alongside the actrapid, yeah. Okay, if they are due for that, okay, so you should give them continuing the long-acting insulin. So tell me few of the long-acting insulin because we are making everybody's life miserable by coming up with the newer insulins. A lot of names.
Humalog, that one.
Humalog is a short-acting. Lantus.
Novorapid.
No, it's already there is no Novorapid.
Levemir?
Levemir?
Yeah.
Levemir we are not using that often now. So the Lantus, okay, they have like the two biosimilar lantus available. They are 20-30% cheaper. So we are using the biosimilar. But you would have heard Semglee and Abesaglar. Okay, they are like the biosimilar for the lantus. Yeah, so Semglee, Abesaglar, and the lantus glargine. Okay, that's three. And then we heard Tijeo, and then Tresiba. Yeah, okay, these two like they are ultra long acting. Okay, so if they are on these 5 insulin, and then obviously Levemir, yeah, okay, but Levemir nowadays we are not starting it, but there are few people that they are on a Levemir. So if they are on Levemir, okay, so you are going to continue those the long acting insulin, not the intermediate acting insulin. Like if you common on like Novamix 30, Humalog Mix 25, Humalog Mix 50, they're all like the intermediate acting insulin. You're not going to. So only the long acting insulin that you're going to start. Yeah. Okay. So yeah, you all like familiar like now up to step 5. Okay. So if you're following up to step 5, yeah, okay, then it should be okay. And then you need to know what is the resolution of the diabetic ketoacidosis. Yeah. The resolution is ketone less than 0.6 for 2 consecutive times. Means like they are measuring like an hourly ketone that they are doing. So 2 consecutive times ketone less than 0.6 plus the pH over 7.3. Yeah. They do not want to use the bicarbonate as a surrogate because we are giving too much of the sodium chloride like hypochloremic here. So they do not want to use. These two things need to be met. pH more than 7.3 and then 2 consecutive ketone is less than 0.6. That's when like you are going to say that's the resolution of DKA. Yeah. So when this happens, the resolution of DKA, okay, what will you do to the patient? One, you're stopping the 10% dextrose. Yeah, that's important. Yeah, okay. And then what is the other thing that we are giving to the patient?
You take them off the fixed rate and put them off the, take them off the fixed rate insulin.
Two,
Variable rate.
you want to convert it from the fixed rate to variable in everybody?
Oh, dependent rate.
That's the important the question to be answered. Yeah. So when they are the resolution of decay happens, okay, and then the patient is able to eat and then drink normally, then what will you do?
Back on the
Normal insulin. So if we have given already, the long-acting insulin, okay, that's where it helps you now. Okay, even if it is a midnight, yeah. So they've already had the long-acting insulin, so you can switch off the fixed rate insulin infusion immediately. Otherwise, traditionally, what they will be like, say, okay, let the patient eat, and then 30 minutes later, they switch off. That's what everybody would be saying. But if you've given the long-acting insulin before, even if it is a midnight, they are not due for the meal. There's no need of continuing the fixed rate insulin infusion, isn't it? That's why you stop it. Yeah. Then if they're able to eat and then drink, so when they are taking the next meal, then they should have their normal whatever the short-acting insulin that they need to take. And then when the next time comes for the long-acting insulin, that yeah, okay. So it is to facilitate that the conversion smoothly. Yeah, okay, you understand. Okay, that is the main reason. Okay, but the another additional reason is that you are giving some more insulin that could help expedite the clearing of the ketones slowly, yeah, from the subcutaneous. That's the other reason. But whatever reason, okay, at the end of the resolution, if they are not able to eat and then drink, say most of the time they come predominantly it's the gastroenteritis. That's what they come up with. You see most common. So they are still vomiting. Okay, so they're still not able to eat properly. Okay, that is the only reason. Okay, you are going to convert the fixed rate into variable rate insulin infusion. Yeah, understand? Yeah, okay, that's another important. Yeah, okay, so the learning now. Okay. This is what it says. The conversion to subcutaneous insulin. If they're able to eat and then drink, they need to go immediately. But whatever reason, if they're not able to eat and then drink, okay. Another one learning point, okay, that variable rate insulin infusion, okay, should be used only if the patient, the type 1 diabetic patient, if they're not able to eat and then drink, not for high blood sugar. not for making somebody's mind like peaceful, so I'm giving a variable rate insulin. No. Okay, the reason that wherever the situation, yeah, okay, not only in ED, anywhere in the hospital, the variable rate insulin infusion should be used if the patient is nil by mouth and they are on insulin in type 2 diabetes, or if they are type 1 diabetes. Obviously, they are on insulin. Okay. And then another thing, like now I have not put it there. So if you are using the variable rate insulin infusion, what is the fluid of choice?
So dextrose with half a saline and potassium added together.
So if you have a half normal saline, yeah, that's a dex saline with a 40 millimole KCl, or if you don't have a dex saline, 5% dextrose with a 40 millimole KCl, the standard rate is 8 hours. So that is the only fluid that should be given. Why I'm just telling, if I give an example, staff who work here admitted with alcoholic ketoacidosis, yeah. Then initially blood sugar is a bit on the higher side. They put her on the variable rate insulin infusion. They're not added a potassium. She had a hypokalemic cardiac arrest and she died. Okay. I'm just giving the the extreme so that it will stick into your mind. Yeah. Okay. Why that it is important. Okay? Yeah. Okay. So 5% dextrose with the 40 millimole KCl, or dex saline, half normal saline with the 40 millimole KCl over 8 hours. Yeah. That should be the fluid in the variable rate insulin infusion. Yeah. Okay. I think so.
Sorry, I just want to mention some caveats. Some trust does not have a liter bag, so you need to measure the 500 mils, so you need to have to do the potassium and give it all 4 hours. Then you can repeat the same.
Yeah.
To maintain
So if
the
there is
same concentration.
same concept. If the principle is 1 liter, that should be 40 millimole. If you are giving a 500 mil, that should be 20 millimole. Yeah. Okay. But it is 8 hours. The 1 liter over 8 hours. Yeah. Okay. So this patient, yeah. Look at it, yeah. Okay. The what I'm for you to concentrate here, the ketone core, it's not improving. Yeah. This is what the actual chart for that particular patient.
So she would have needed her insulin infusion rate to be increased if her ketones weren't falling. And she was also very acidotic when she presented, so there probably should have been some sort of critical care review on admission.
Yeah. Okay. So you're picking up. Yeah. Okay. Now the severity, now you're picking it up, and then now they are not responding to the treatment. Okay. So if you come across this scenario, yeah. Okay. So you have but the patient condition is not improving. Okay. What will you do? What could be the most commonest cause that the patient's condition is not getting better?
Check how much they have actually received too, along with it, because
This is where I told you before. That's what he's saying. Dave is saying that's correct. Yeah. Okay. So you've been asked to review that patient. Okay. So say they've started say this time there is a time there. Yeah. Okay. At the top will be there. So 2 o'clock in the morning. Okay. So you called at 6 o'clock, and then or you picked up. Okay. That's not been escalated. So now you learned. You picked it up. Okay. 6 o'clock. Yeah. Okay. So that means the most commonest issue is somewhere along the IV axis. Yeah, because you're saying that that patient needed 2 cannulas. In that one cannula, there will be normal saline going in. Another will be the insulin going in. The other cannula, if needed, the 10% dextrose will be going. Okay. So what could happen to the cannula site or in that in tissues? Either it tissued, the patient wanted to go for a V, they switched off, they're not connected, they keep the hand like this, it is kinked, Yeah, this is very simple, but that is the most commonest issue you come across. So if you use the knowledge, you can do mini detective work then. So it's 4 hours. Yeah. So by 4 hours, you should be knowing now how many liters of the fluid this patient should have had it. That means a minimum 2 liters should have gone, and then 2.5 liters, should have gone by 4 hours. So if that patient is only on 1 liter that had gone, you know that that patient was not adequately treated. At the same time, in the insulin infusion, it all starts with 50 units, isn't it? So at the end of 4 hours, if there are the 7 units or 7 mil per hour, the end of 4 hours, 24 mils should have gone in that the syringe driver. But if there's only the 10 mils had gone, then you know that patient has not received. Yeah, that should be the initial assessment. Okay, but in this patient, there's something else that happened. So you looked at it. That's all correct. Yeah. Okay. The line is correct. The amount of insulin, amount of fluid that they've received are all adequate. But in spite of that, ketone is not improving. Then what will you consider? Sorry. Obviously, to start with, somebody to keep increasing the insulin infusion rate. Okay, I'm making it next step. You're increasing the insulin rate, but still, the patient ketone is not improving. What will you think different is?
Would you be worried about their kidney function?
Okay, now you're thinking laterally, yeah, you're going. Is there anything else which is making it not getting it better? Say if they're a kidney failure, the AKI, they're not producing any insulin. Sorry, they're not producing any urine. Yeah. Or is there something else that precipitated that we are not addressing it? I told you most commonest is what you said.
Insulin compliance.
No, the insulin complaint. Apart after that.
Infection.
Infection. So now you say it's a very bond or pneumonia there. It's a right side fully. So you would expect the response in that particular scenario will be different. Okay. This patient, okay, then somebody went and then reviewed. And she said, "Oh, I have some pain and then swelling in my thigh." When they were examined, an abscess collection. Okay, so then this patient went to the emergency surgery IND, yeah, okay. The first 100 mil first was taken out, okay. Then it improved. The other scenario is any stress will precipitate the DKA, isn't it? Which we don't commonly look at it. An MI or a stroke. So you need to think. That's why when you're doing the initial investigation, you're all looking at it. Yeah, okay. The ECG that you will be looking at, is it an anterior MI? So if you're not addressing the anterior MI, that's where a lot of lactic acidosis that is producing. Okay. That we are treating is this, but we are missing it there. Yeah. Okay. That's when you should be thinking. That's why when you are the step 2 when you're doing it. Okay. These are all the things should count. Okay. So you need to have it in your mind. Everybody will be having ECG, everybody, yeah, okay, but I think we need to concentrate, I think, on that particular patient, why I'm looking at the ECG, yeah, okay, not say, okay, normal sinus rhythm, and just as a tick box exercise, yeah, okay, that's where you should be thinking, yeah, okay. If it is not improving, am I missing something? Is there any other obvious precipitating factor, or is it becoming a bit more complicated, or has the patient not received adequate amount of the fluid and then the insulin as per the guideline? Yeah, so that you should be thinking. Yeah, okay. And this one, what important one thing there?
Potassium is low.
So I've told you now. Yeah.
Yeah, that's what to you.
Thank you. So you're not going to start with the insulin infusion. Yeah. So So now you're going to think it in a different way, how I can like know as quick as possible, as safe as possible to bring up the potassium. Okay, what are the measures that I'm going to do? Okay, like if I'm giving in the first bag, like adding like 20 millimole, yeah, and then getting another IV access or calling the ITU whether this patient will. So in this patient, if you start with the insulin infusion, you are going to produce hypokalemic cardiac arrest. Yeah, that's very important. Yeah, okay, and then obviously like she's a bit hypotensive, tachycardic. Okay, so when you look at it, this are all like goes towards like the severe DKA. That itself like warrant level 2 care, level 3 care. Yeah, yeah, okay. And then the third, I think the scenario. What do you think? Like that is unusual from the other two. What do you think?
Yeah.
That's very important. Yeah. Okay. So majority of time, like they do the VBG and then they just come and then give it to you. Okay. That's where like there are a couple of events that happened. Yeah. Okay. That's why I wanted you to like think it. Okay. So GP, I've already put diabetes. Okay. But now you want to know what type of diabetes this patient would want. Yeah. Because now type 1 diabetes, they are living up to 70, 80 years. That okay. But commonly in that age group, that what we come across is that the type 2 diabetes. Yeah. Okay. And then some abdominal pain and then vomiting. The blood sugar is 10. Yeah. It's A&E waiting room. What other information that you're going to ask, or what other information do you need?
Are they insulin controlled?
Okay, one.
The previous episode of DKA.
Episodes of DKA,
Ask for capillary ketone?
capillary ketones. But if you're asking capillary ketones, I will ask why you're asking capillary ketones. Because of the teaching, it's still like the ketoacidosis. Yeah, okay. But why different?
We only do ketone check.
Could he be taking any oral hypoglycemics?
That's where like now I'm coming. Yeah, oral hypoglycemics. If somebody on oral hypoglycemics, that predominantly they are type 2 diabetes. Yeah. As I've told you, or as told you before starting, what is that the entity that you have to think? So in which patients, in which type 2 diabetic patients, that the euglycemic DKA is more common?
SGLT, the oral hypoglycemics.
SGLT2 inhibitor. Have you heard SGLT2 inhibitor?
Empagliflozin.
Empagliflozin. There's 3 more. Dapagliflozin. Canagliflozin, yeah. Okay. There is another 2 like ertugliflozin, sotagliflozin. Those 2 that we are not using. That. Have you heard about the SGLT2 inhibitors? Empa, Cana, dapagliflozin. What's the benefit? Like now, who are all now interested to use this medication?
They help with weight loss.
Weight loss, yeah. Okay.
Yeah, the main mechanism is that the glucose is flushed in the urine.
Yeah.
They're less prone to hypo. Less prone to getting hypos.
Less prone to get hypos, yeah. Okay. But what other the other specialist team they want to use?
In heart failure patients as well.
Why they're using in heart failure patients?
Because it encourages diuresis. So if you've got patients that are overloaded with fluid, you can use it to help control.
Okay. The SGLT2 inhibitors, as you will be seeing more and more people on, in more complex patients on the SGLT2 inhibitors, because the mechanism is it prevents the glucose being absorbed, so they lose the sugar. So it's an insulin independent mechanism, so it does not cause hypoglycemia. Another advantage, when people lose sugar, the body needs to find an alternate source of energy. They use the fat, thereby 2-3 kilo weight loss. Yeah, that's why the weight loss. no hypos, and in a lot of trials it had shown, I'm just simplifying it, it reduces the new or existing heart failure or heart attack by 30%. It reduces new or existing proteinuria, kidney failure, people need to go into dialysis by up to 50%. So because of that, cardiologists want to use it, the kidney people want to use it, diabetologists want to use it. Yeah. And now more and more people, and then they have relaxed the criteria. And previously they wanted to use only when the EGF are more than 60, but now you can start even up to EGF or 15, and then even if it drops below, then we can continue. So then you will see like a CKD patient coming with, yeah. So you need to think of this particular condition, euglycemic DKA. Or if you want to explain either why what happened in this in A&E, there's a patient they didn't take that to the history. So we went to Ward 29, and then they picked it up. It's already 24, 36 hours that patient had in the euglycemic diabetic ketoacidosis. Yeah, I think the recognition is important. If you don't think, then you will not, make that to the diagnosis. As I told you, it's now becoming used more and more commonly. Okay. Now I think if you look at the, if you have, I think in busy ED department, you need to try to find out if the patient is on, if they are especially type 2 diabetes, if they're on this SGLT2. Obviously, you can look at the GP clinicals, okay, or if it's not there, I've told you the diabetes team is using, renal team is using, and then the cardiology team they are using. So you may look at the, the letters, most recent letters in that, whether they have mentioned anything, okay, and whether you would think, yeah, okay. So in those patients, even if they come with the non-specific symptoms, some vomiting, some abdominal pain. That's what I have put, they present a non-specific, generally and a bit of vomiting, bit of abdominal pain. Yeah, okay. So in these patients, that's where the another indication, yeah, they were saying that when the blood sugar at the presentation itself less than 14, whether you would start with the 10% dextrose, yeah, and then you would consider reducing the fixed rate insulin infusion from 0.1 to 0.05. Okay, leave that for the specialist team to make, yeah, okay, but at least recognizing that's very important, yeah, okay, euglycemic diabetic ketoacidosis, yeah, okay. Say you start with 0.1 unit, but if it's rapidly dropping, then you need to consider to 0.05, yeah, okay.
And fluid wise, first bath,
still the same. Euglycemic decay also still the same.
But do we just simultaneously also start the 10% the first bath?
That's what maybe, because if the blood sugar is less than 14, okay, that you're thinking you need to start with the 10% dextrose, but that's where it becomes even more difficult, because I'm starting in heart failure patient, I'm starting in the CKD patients, okay. So it's, even though we say it looks like simple, but the patient is the complex, okay. So the fluid replacement, we have to be even more careful.
So are there anything about 20% glucose, especially in patients with heart failure or
I think, yeah, that's where we are now going outside the box, thinking outside the box, yeah, okay. These are all things they have not included in the guideline, okay. So then we need to think, okay, so whether instead of the 10% dextrose, if you make it as a 20% dextrose, you are concentrating it, isn't it? So instead of a liter, you can give only the 500 mil, okay. That so 500 mil over 8 hours, so you're reducing. In patients I have in the heart failure and the renal failure, I have given a dry sliding scale. That means I have not given any fluid, but continued only the insulin. Because in the CKD5, if I give a liter bag, they go into pulmonary edema immediately. Okay? So that's why I have given a dry sliding scale. So these things, that's when it's going to be more they become severe, complicated type that you are going to ask the senior type. Because Davis, NIS5, ST5, 6 that is already considered senior that is asking all these questions. But you guys, yeah, okay, just think, okay, yeah. I think like the time is not there, so I think what I want to like from the DKHHS, yeah, okay. Attention to like what's the obvious like the precipitating, okay, and then step 1, 2, 3, 4, 5. So 4 and then 5 interchangeable depending upon what's the potassium situation is, and then when you need to add the potassium from the second bag onwards, the first bag need to be given as a stat if circulatory collapse, yeah, okay. Then if it is hypokalemia on presentation, you're asking senior help. The 10% dextrose you are adding when the drops below 14, and then the resolution, and then you are continuing with the long-acting insulin if they are already on. The resolution is when ketone less than 0.6 and then pH more than 7.3, and then think like the euglycemic diabetic ketoacidosis. Okay, I think I hope like I have covered like all the practical aspects of like the diabetic ketoacidosis that so far like we have encountered what the problem areas and then I've addressed it. Yeah, and thereby I think now like you can make improved effort, okay, to improve the outcome for the DKA patients. Yeah, is that okay? Anybody from the teams that they want anything?
Nobody's put any question there. One thing I think last time we had a couple of incidents times that potassium was high to start with. It was should we give how should we start the insulin for hyperkalemia and DK?
Yeah, okay. I think that like I have like went back and then I've also researched like the initial presentation hyperkalemia in the DKA. Okay, it's there are not much like the reports to say like the incidences, but if that comes, okay, so then like we are going to think what's that like which one is that the priority? Is that the hyperkalemia? Is that the one like the priority that you want to address it that separately? Okay, and then like it becomes like two different entity, okay, and then depending upon which one is going to take like more onerous, okay, so you're going to address that one first and then like okay, the traditional like the way I would be approaching then, okay, depending upon the patient situation, if the potassium 7.5, I will be giving the calcium gluconate and the insulin dextrose, yeah, okay, and then salbutamol nebulizer, those like separately that I'm going to give it, okay. If it's say like somewhere like the 6.2, 6.3 something like up to 6.5, okay. If there are like no ECG change, you are going to give the other thing like the brings. When are you going to give the calcium gluconate and then insulin dextrose, or what potassium level that you are going to give it? Are you going to give it in 6 millimole, or what level like the guideline says?
Of 6.5 on the ECG.
So if it is 6.5 or above or ECG changes, then only like you need to give the calcium gluconate and then the insulin dextrose. Yeah, okay. So if that is the situation there for you, okay, so 6.5 and then above you are going to do, but like below 6.5, okay, with no ECG changes, you don't need to give the calcium gluconate, you don't need to give the insulin dextrose. Then like you start, the DKA treatment, okay, what it is going to do? It's going to drive that to the potassium into the, anyway, you're not going to give that 20 millimole in the second bag, yeah, okay, you're going to monitor it, yeah, that's how like now I will approach it. Yeah, thank you.
Any questions here?
With the insulin infusion, so at what point would you start that? Sorry.
Told you the resolution of the DKA.
Oh, okay.
Less than 0.6 ketone 2 consecutive times with pH more than 7.3. That's when like now we'll be stopping it.
So when would you start it? So obviously you start with the fluid replacement as the most important, and then
as soon as that. Yeah.
Oh,
so I'm just saying like because I'm making it like easier for you like as a step, okay. But in the practically, okay, so you will be sometimes like doing the step 1 and then step 2 like you will be doing simultaneously. But when you're doing As soon as like you establish the DKA,
Yeah.
step 3 like also you can start it. Yeah.
Start it,
Okay. So it's not like you do step 1, step 2, and then step 3, step 4. It's like for you to understand. Okay, I'm just compartmenting. Okay, but in actual practice, okay, if I say like in somebody like comes with exacerbation COPD,
Yeah.
I will be giving the back-to-back nebulizer. I'll give the steroid. Yeah, and then the simultaneous like now I'll ask for the X-ray.
Yeah.
Like that. Yeah. Okay. So that's for you like to understand it like a bit more easily. Yeah, taking it.
Thank you very much.
I think another important, I think Arif like asked, and then I also need it. Yeah. Okay. Guys, please just scan and then do the feedback. Yeah. And then tell us like if anything that we can improve it.
What I tell you last time, Dr. Senthil Kumar, that was my mistake.